Hello everyone, it's Dr. Halim Jaffer. I am periodontist and I'm about to continue my previous lectures, which was about the history and examination. We reached to the social and medical history. So I'm trying to go in sequence so as not to jump on any subject. From the history and examination till the diagnosis and treatment planning. So, in the social history, details of patients' occupation, diet, and consumption of alcohol or cigarette smoking should be considered. Stress induced by examination or divorce or change in employment should also be noted, as these kind of things like stress, for example, may aggravate existing tooth mobility due to bruxism. The stress patient having bruxism, most of the times clenching, or some kinds of habit like nail biting, pencil bite. So this may aggravate the existing tooth mobility from periodontal disease if there's periodontal disease. And if there's not, some patients' habit may affect directly on the tooth surface. Stress has been shown to be associated with the delayed wound healing of both connective tissue and bone, and may cause necrotizing ulcerative gingivitis or enhance, because it's a predisposing factor, not the causative factor. And also it's a predisposing factor in case of chronic periodontitis. As most patients have some elements of stress in their lives, the potential influence of this stress on periodontal disease should be appreciated. A lack of ability to cope with the stress, and particularly the financial strain, has been implicated as a specific risk factor in periodontal disease. Nowadays, the stress is one of the most important risk factor indicated as a predisposing factor for chronic periodontitis. So, this is regarding the social history. The social history, including any familial history of the patient, which may affect the progression of the periodontal disease. So it includes, for example, occupation, diets, smoking, and alcohol consumption, and as a main factor, which is a stress. I think the stress and smoking consumption or cigarette smoking is two major factors that act in aggravating the periodontal disease. So we are jumping to the medical history. A thorough medical history must be recorded and updated at each visit, and the patient's perception of their present health is also a valuable indicator of their psychological makeup and potential compliance with the treatment. So, through an overall view of the patient's medical history, you can check the psychological makeup of that patient. A patient with a history of rheumatoid fever, or for example congenital cardiac defects, or prosthetic heart valve, it's important to know in the medical history that these patients doesn't require any prophylaxis before treatment. And in the Middle East, this is one of the most faulty things that dentists did for many years till now, that they prescribe antibiotic for almost everything. But even for these diseases, rheumatoid fever or prosthetic heart valve or congenital cardiac defects, actually prophylactic antibiotic is not indicated. Also, patients with a pacemaker doesn't require any antibiotic prophylaxis. While ultrasonic scaler can be used in patients with cardiac pacemaker in accordance with the manufacturer guidance. So, and this is also, there is a faulty information regarding the pacemaker, that you can't use the ultrasonic instruments. You can use it within the manufacturer guides. So each manufacturer have some guides that relate to their factories. So you are going according to the guidelines. Because most of them doesn't need to be outdated from the treatment plan, the ultrasonic scaler, because they normally recommend that the ultrasonic handpiece and cable should be kept at least 15 centimeter away from the pacemaker device. And a diabetic patient are at particular risk of periodontal breakdown, especially when a poorly controlled diabetic present. A positive familial history should be noted, and it is vigilant periodontal monitoring undertaken. Regarding the HIV positive patient, they are also at high risk from very extensive and aggressive periodontal breakdown. So the HIV patients are, because of the impaired immunity, with the diabetic patient also, in these two having a problem in immunity, in immune response. So you may find a huge periodontal breakdown in these two diseases. And patients with food fads or unusual diets should be questioned as a part of an overall dietary analysis to evaluate their vitamins and protein intakes, because nutritional deficiencies may modify the severity and extent of periodontal disease by altering the host response. And if you have a deficiency in the food and nutrients, you may lose a potential resistance of repair. Although such deficiencies are less in the Western country, but in undeveloped country, actually, we can see it in a more version. Also, gastric hyperacidity and reflux from hiatus hernia and gastric ulceration predispose to erosion and root caries, especially if you have an existing gingival recession. Also, in medical history, a pregnant lady should be taken into consideration, and special precautions should be made for the pregnant ladies, which may talk about in another lectures. The relationship between the effects of the medical histories or medical conditions on the periodontal conditions. And in the current medications of the patient, we should note that we should take a dosage and type of medication into consideration. For example, when a patient is receiving anticoagulant therapy, the general medical practitioner or patient's physician must be consulted with a view to modify the anticoagulant dosage to coincide with the invasive periodontal treatment, and by that reducing the risk of post-operative hemorrhage. Sometimes you need 5 days before surgical operation, for example, to stop some anticoagulant drugs like an aspirin. And some drugs like phenytoin, cyclosporine, and nifedipine can cause gingival overgrowth, which may compromise a good oral hygiene, leading to aesthetic problem, as long as they also provide a harbor for bacteria by producing a false pocket. And for patient taking bisphosphonate, the extraction and surgical operation should be avoided because it will increase the risk of osteonecrosis. Antimicrobials often used in the treatment of periodontal disease are contraindicated for certain patients. First of all, for whom of unwanted effect of the drug that may be enhanced, or because of the potential interaction with the drug that the patient is already taking. So some drugs like cyclosporine, as we talked about, nifedipine, phenytoin, may cause an unwanted effect. This is one of the reasons that some drugs are contraindicated. And the other one is the interaction between the drug used for the periodontal treatment and the drug used for medical treatment or general medical problems. And by here we stop for now, and we will continue in the next lecture. Thank you, and I will hope to subscribe to my channel, HL Talent. Thank you.